Good afternoon, everyone. Welcome. We're going to go ahead and get started, so feel free to help yourselves to lunch if you have not yet and find a seat. Thank you so much for coming today to the 26th Annual Martin Luther King Jr. Celebration here at the University of New England's Portland campus. It's a cold, dreary day. I always get a little nervous with the MLK Jr. celebration. We've actually had keynote speakers that have been holed up in hotels when school's been canceled. So no snow today, no major storms. Our keynote arrived safely, so it's a good day. My name's Donna Gasper-Jarvis, and I am the director of the UNE Office of Multicultural Affairs and Diversity, and really pleased to be hosting today's MLK Jr. celebration event along with our co-sponsor, the Interprofessional Education Collaborative, as well as support from our graduate programs in public health and the Center for Community and Public Health at UNE as well. For those of you that don't know, UNE has a long and proud history of celebrating the Martin Luther King Jr. celebration. On our Biddeford campus, when it used to be St. Francis College, back in 1963, Dr. King actually spoke at a civil rights symposium. So we're really proud of that legacy and of being one of the only few sites in Maine where he came and visited. And we have a remarkably well-known and highly regarded keynote speaker for our MLK Jr. celebration here today. There's been a lot of excitement both on the UNE campus and also in the larger community about him being here. And we're really honored to have him be addressing us this morning or this afternoon. Just to give a little context to today's program before we begin, our theme this year is beloved community, and this was a concept that Dr. King spoke about and wrote about quite often. It was a very big, lofty vision. So I'm just going to share a little bit about Dr. King's vision of the beloved community as according to the King Center in Atlanta, Georgia. In Dr. King's beloved community, it's one in which all people can share the wealth of the earth. Poverty, hunger, homelessness will not be tolerated because international standards of human decency will not allow it. Racism and all forms of discrimination, bigotry, and prejudice will be replaced by an all-inclusive spirit of sisterhood and brotherhood. Love and trust will triumph over fear and hatred. Peace and justice will prevail over war and military conflict. And if conflict does occur, which it inevitably will because we're human, then that would be resolved peacefully, and adversaries could be reconciled through a mutual determined commitment to nonviolence. And all conflicts in the beloved community should end with reconciliation of adversaries cooperating together in the spirit of friendship and goodwill. So last week when we talked a little bit about Dr. King's beloved community on the Biddeford campus, our keynote speaker there, Dr. Christopher Emdin, I think put it best. He's like, why don't we all just sing Kumbaya? Because it seems such an idealistic and lofty goal, but it really boils down to one thing. It boils down to people getting along and joining together in the spirit of collaboration for the common humanity. And there's so much, there's so many examples of that beloved community happening right here at UNE. Everything from the interprofessional collaboration, where students are coming together to learn and work together in collaboration in the community and in clinical practice and in education and service. There's some wonderful grants and research and service projects that are taking place through our Center for Community and Public Health and many of the other offices on campus. So I can't think of a more well-respected person to come and address us today about building community and the concept of beloved community than our keynote speaker. And I'd like to invite Dr. Dora Ann Mills, our Vice President of Clinical Affairs, to introduce Dr. Georges Benjamin. Thank you.
Thank you very much. Thank you. Thank you so much, everybody coming out. I know today it is really, I think, one of the dreariest days I remember seeing out here in a long time. It was even hard to see the Ledke Auditorium through the fog across the quad. It is truly a delight to have Dr. Benjamin here. And I have to share with you that just last week, my husband and I took our 3 children to the inauguration. And we almost went 4 years ago and decided it was so crowded and the kids were young enough that we thought we'd wait. And we were just coming off from really a mountaintop. We started actually our weekend there by taking the children to the Holocaust Museum, and which is right near the National Mall. And it was, it was a pretty tough thing, but I knew that they were old enough that we needed to talk about that chapter in our horrible human history. But as we exited a couple of hours later, we walked down the mall, and we walked across the World War II monument, and we talked about how both of their grandfathers fought in that war to overcome Hitler and the atrocities in Europe. And then we walked farther down the mall to the Lincoln Memorial and read the quotes from Lincoln from his second inaugural address, which was all about justice and against slavery. And we read that address together. And of course, then the Gettysburg Address is also on the other wall. And we stood at the spot where Dr. Martin Luther King gave his address. They now have it marked on the top step of the Lincoln Memorial. And we actually took a picture of all 5 of our feet standing around spots where it's marked, and took a picture like this so you could see our feet around. And then we walked over to the Martin Luther King Memorial, which just opened up a year and a half ago, which when you're in DC, you definitely should see it, and with all of his quotes. And we walked across around the basin there to the FDR Memorial and the Jefferson Memorial. So by the end of the day, we were really filled with, I think, the inspiration from all of these Americans who put justice and equality at the center of their goals and their values, and how critically important that is. Because when you don't embrace justice and equality for all, you can have something happen like the Holocaust. And then, of course, a couple of days later, we were amongst a million other people listening to the president's inauguration speech. And if you didn't get to hear it, I really recommend that you read it at least. The New York Times and Washington Post have the text of it. It was all about justice and equality for all, and it was just beautiful. You can tell I'm getting all teared up just thinking about it. And so this is particularly poignant for me to come back to UNE and to return home here and have Dr. Benjamin with us, who has led our nation's leading public health organization, the American Public Health Association, for 10 years now. And of course, public health, at its core value, is justice and equality for all. Because we in public health know that we cannot all be healthy. We cannot all have the opportunity to be healthy unless there is justice and equality. Those are the values that Dr. Martin Luther King stood for, and they're also the values of public health. And so it is just very striking that we have today with us the head of our nation's Public Health Association, and a very great honor that he's here. Dr. Benjamin is an MD. He is from, I think, Illinois originally, at least that's where you went to medical school. I remember him because when he was the Commissioner of Health for the state of Maryland in the late 1900s, late 1900s. Oh dear. It's only Tuesday, what is it? I don't know what day it is. Wednesday? Oh my goodness. It's only Wednesday and I'm flubbing up. But it's the late 1990s. Yeah, neither he nor I are that old. And his work in Medicaid there was actually very striking because and very notable around the country, because he not only took Medicaid into managed care, but he made it much better. So he improved the quality of the managed care that was being offered by Medicaid, so that Medicaid, of course, is the insurance that serves mostly people with low incomes and disabilities. So for them to have a higher quality of insurance available to them, and therefore higher quality of health care, was a very tremendous success in terms of equality and justice for people living with low incomes and disabilities. And then he also was, he actually, as a note, he was actually also the head of emergency department for Walter Reed Hospital, and was a commissioner of health for the District of Columbia. So he has a tremendous history, and especially the last 10 years, we in public health have greatly enjoyed his leadership at APHA. And we also have with us today the president of our main public health association, the affiliate of APHA, which is Denise Bessian, who's the director of our NPH program. So without further ado, welcome Dr. Benjamin to UNE. Thank you.
Well, hello, everyone. That's kind of weak. Let's try it again. Good afternoon. Oh, that's much better. Well, let me thank you very much for having me here today. I'm really honored. I think this is my third or fourth trip to this wonderful state, and every time I come, I really enjoy the beauty of the state and the wonderful people here. But let's get started. You know, the talk today is to talk a bit about building healthy communities. And I often start my presentation with a quote from a very famous comedian, Moms Mabley. And those of you who of my generation know that most of what Moms Mabley said could not be repeated in polite company. But she did say many inspiring things. And one of those, of course, was that if you always do what you always did, then you always get what you always got. And I want you to think about that in the context of health care, and really how we build healthy communities. And I know there are those listening to this that are not here in the room with us today, but you know, this is a slide that shows the health outcomes based on expenditures for most of the industrialized nations of the world. And it's kind of a scattergram, but what it does show is that the United States is an outlier, which basically means that we die sooner at a higher cost. And of course, I think our central challenge for those of us in the health world is for us to move the United States into the pack with everyone else. This is a major challenge. It's going to take a lot of work. But that really is our goal, is to try to get everybody into the cluster, which ultimately means living longer, better, with more value for our healthcare dollar. It's cost can be lower, but at the end of the day, it's really about value. This is obviously a very famous quote of Dr. King, who talked a great deal about the issue of health and equity, and I think everybody kind of uses this quote now when they think about Dr. King and equity, but the point is that the fact that people do not have the opportunity for health, despite the fact that we often talk about life, liberty, and the pursuit of happiness, the corollary to that is you can't get that, any of that, unless you have an opportunity for health. And so while there are many people who would argue that health is not a constitutional right, there's no question that's a human right by virtue of the fact that you can't do any of the other stuff unless you have the opportunity for health and you can be healthy. Now, I would also argue that, you know, I'm an ER doc. I trained in internal medicine, practiced emergency medicine. And when I see a picture like this, and this is a picture of a very high-intensity emergency department. It has all the bells and whistles, you know, $25,000 stretchers, poles, monitors of all kinds. They blink, you know, think lights that blink green and red and make sounds and do all kinds of stuff that just makes an ER doctor excited, okay? The problem is that we have too much of that. You know, we have too much of that in our health system and not enough of this, you know. Not enough people actually doing primary care. You know, I was taught very early in medical school that if you shut up, listen to your patients, you can diagnose most of what's wrong with them. And then if you then examine to them, you can figure out the rest. And you can do a few tests if you absolutely need to for diagnostic purposes. And our system's been turned on its head. You know, someone walks in the room with a chief complaint, which may have absolutely nothing to do with why they actually walked into the room. We order a battery of tests. And then we do the physical examination and take the history to make sure that it validates the test that we do. And we've done that with our health system, right? We've turned it on its head. And we need to do some things to try to change that. And I think the population health approach to this is one way for us to begin that process of really repairing our whole system and improving our health. The whole idea of achieving health particularly individual health, is a very complex process. You know, as many of you know, I've struggled most of my life with my weight, certainly most of my adult life with my weight. And if it was as simple as eating less and walking more, if it was just that simple, you know, I'd look like Twiggy. But it's not that simple. Where we live, the environment in which we live, behavior plays a big role, but there's a range of other factors that dramatically influence the health and well-being of both individuals and ultimately the health and well-being of communities that we have to address. So let's start with health insurance, because we've just gone through a big national debate and reaffirmation by the Supreme Court of an expansion of health coverage for people. So let's talk about health insurance first. Now, some would argue that access to health care is very important, and health insurance is very important. And I got to tell you, at least from a population-based perspective, we know that about 44,000 people die prematurely each year because they simply do not have health insurance. And again, I often get people that argue with me about that, except I've been an ER doc, and I know what happens at 3 o'clock in the morning. The first thing that anybody asks you is, what is their health insurance? Not only when you come into the emergency department, but when they want to refer them anywhere at all. It's the first question. It's not hello, all right? It's not how are you doing. It's what is this person's insurance status? So insurance is the way that we provide care in this country. It's the get into the system card that you need, and it absolutely is an essential component. So I've argued strongly for universal health care for all Americans, and I would encourage you to encourage your elected leaders and others to move that ball forward as well. Healthy people, unhealthy children cannot learn, and unhealthy adults cannot work. And so this is an essential component of that. But it's, you know, it's not everything, but it's very important. We continue to argue, by the way, whether or not the Medicaid program, as an example, works. You know, you have all kinds of people that make excuses around whether Medicaid works or not. And I got to tell you, Medicaid does work, and there's some really compelling evidence. We've done a lot of studies over the years looking at simple things like school absenteeism and asthma, reduction in asthma and reduction of hospitalizations and things like that. But there are two very interesting studies I just want to bring to your attention. First, I want to talk about barriers, because people would argue that if you don't have health insurance, you can get it. The emergency room is a place to get your care. As an ER doc, I can assure you that that's not true. Anybody that tells you that that's true is wrong. This is not a debatable issue. They're just wrong. There's some things in which you're wrong. This is one of those where you're just wrong. ER docs manage emergent hypertension. But if you got a little bit of hypertension, the one that actually results in severe progressive congestive heart failure, they don't treat that, okay? They treat high blood pressure that will cause you to have a stroke right now, but not high blood pressure that's going to cause you to have a stroke 2 weeks from now. And people need to understand that. So anyway, this slide here shows that there are some barriers to health care, that people who have no usual source of care or don't get preventive care if they don't have health insurance. That people and children, simply looking at children in terms of their access to care. It's not just for adults, because people often assume that all kids are covered. Well, that's not true as well. Kids who are uninsured are less likely to have a usual source of care, unlikely to get preventive services, unlikely to get anything except emergent services. And that's because we have a law that requires universal access to emergency care. It's actually a mandate for universal access to emergency care. So here's one of those studies I was talking about. This is a study that was done, which was looking at mortality rates for the non-elderly after a state expanded their Medicaid program. And what they found was there was a significant reduction in mortality. They looked simply at mortality. And it was related to the increase of Medicaid, everything else being equal. So again, this is a fairly recent study looking at a population which said that. So Medicaid expansion, less people died. Another study in Oregon, you know, the randomized controlled study is the gold standard for studies. And Oregon had an opportunity to do an ethical, we believe, randomized controlled study. They knew they were going to expand Medicaid. They knew they didn't have enough money to give it to everybody. So they did a lottery for those people that were in the eligible category. And so some people got it and some people didn't. But because some people didn't get it, and they had been looked at for a variety of reasons to decide whether they could get it or not, they had basically a cohort of people to look at. And then they looked at the outcomes for those people that got it and those people that didn't get it, you know, as a retrospective study. And it turns out the people that got Medicaid did much better than those people who didn't get Medicaid. This is probably as close as you can get to a randomized controlled study done in an ethical manner. But again, you know, we continue to hear people say, Medicaid doesn't work. And then they would argue that Medicaid doesn't work because doctors won't take it, you know? And then they forget the part that, these are generally governors, the fact that how much you pay providers is the governor's choice, okay? So you create an environment in which practitioners won't participate because you don't pay them adequately, okay? And then you use that as an excuse for why the program doesn't work. Strange circular logic by any way that I think of it. But remind you, anytime someone brings up that argument around the fact that providers won't participate in Medicaid, it was never designed to fully compensate providers for all of their care. But it was designed to provide providers adequately. And in fact, the law requires that the Medicaid program pay them, quote unquote, adequately, whatever that means. And there have actually been lawsuits to try to enhance provider reimbursement. And in fact, the Affordable Care Act now provides some enhanced reimbursement for primary care providers as a way to try to keep them into the program. Now, you know, I just use this as also an opportunity to point out that in the Affordable Care Act, there's a range of clinical preventive services that I think are very important that were going to be enhanced. And so as we begin to look at expansions, there's an amazing opportunity now for us to look at clinical prevention as a way of building the health and well-being of the community. Hopefully, at the end of the day, no one will have any excuse for not getting their clinical preventive screenings that have been shown, evidence-based screenings that have been shown to work, getting all their shots, you know, their vaccinations, really putting prevention into all health insurance plans, both in the private sector as well as in the public sector. This is going to be an amazing opportunity for us to do that. And the Affordable Care Act does now promote clinical preventive services as part of that reform. I also like to point out that it does some interesting things that the public health community has been involved with. Many of you are familiar with the two major task forces that look at the efficacy of preventive services. One that looks at clinical preventive health services. It's been in the news a lot lately. But there's another one that does community-based preventive services. It looks at our walking programs, our tobacco-based programs, and the things that in public health we do on a community basis. And this is the community, it produces a document called the Community Guide. And this is an important task force. And for the first time, both of these task forces were officially cauterized, officially authorized and officially funded through the Affordable Care Act. They codified them legally, so these programs are there. They require that they look at the evidence for what works. I just saw a recent study that said a fair amount of what we do every day in medicine has never been tested and never, nobody really knows the efficacy of it. I can tell you from practicing clinical medicine for over 20 years, that's true. We do a lot of stuff because we think it works, and anecdote is not evidence. So we really need to do the studies to make sure that these things are effective and do what we think they're supposed to do. Now, I wouldn't be sitting here from a public health perspective and talking about this if I thought that insurance would solve all our problems. Health is much, much more than an insurance card. This is a pyramid-looking chart, and for those who can't see the slide, the chart basically points out the fact that a lot of what we do in medicine is on the clinical side, and that if you really want to have a firm foundation to improve health, then we need to do some foundational things around prevention and wellness, which augment the clinical experience. They make the clinical experience much more effective, but are really designed to improve health and wellness across the lifespan. And that we need to move a lot of our interventions upstream to try to deal with some of these issues well before they happen. Now, so we know health is about risky behavior. And I wouldn't, again, be in public health if I didn't talk a bit about tobacco as public enemy number one, the leading preventable cause of death. Over 400,000 people die each and every year prematurely because of tobacco smoke. That if you think that the tobacco industry has given up the task and mission to encourage Americans to smoke, they will argue that they don't go after children, and I would argue that that's not true. And we still see too many of our children who become addicted early from tobacco. And we've seen our tobacco resources to address this problem shrink each and every day. And although in Maine, you've done quite well to try to preserve your funding, and you should be commended for that, by the way, there are other places that have not been as successful in maintaining their funding for tobacco, and that's a shame. Because tobacco is at the root cause of so many diseases: cardiovascular disease, cancer, infant mortality, chronic obstructive pulmonary disease, the propensity to get certain types of pulmonary infections. It's just a real problem that we need to address, and I still call for us to become much more assertive in dealing with this. It is obviously a risky behavior, but at some point it becomes a significant addiction that we have to address. And all these people that still call tobacco use a habit are just wrong. It's an addiction. It may start as a habit. It very quickly becomes an addiction. You know, health is about what we eat and how much of it. Now, I know we're having a big national debate about what we should do about sugary beverages. All right, I confess, I had a sugary beverage for lunch, but I did have water at breakfast. So I don't know if that offsets it or not. But it is about not just having the sugary beverages, but it's also about how many you have. That's the central challenge here. It's about whether or not there are other nutritional components about what we're drinking. All of these issues are very important. But, you know, there was a time when we didn't think about this. You know, it was a time in which we thought a sugary beverage was sexy and cute, and we showed very athletic people drinking their sugary beverage before they threw their jersey, their football jersey, to a kid. You know, we really encourage people to drink our sugary beverages. And the challenge is that we now need to make sure that we understand that there are many ways to address this problem, and they are central. Dealing with sugary beverages is essential to us dealing with our obesity epidemic. There are some other things which we're going to talk about, but it's essential that we understand that this is a problem, and that we explain this to kids so they can make informed decisions, and to their parents. So instead of putting a sugary beverage in their lunchbox, and maybe they put a bottle of water. Or if they're still going to get the same sugar contents, at least make sure it's a juice or something that has a little bit more nutritional content to it. This whole idea of knowing what we eat is important. We're now being called the food police because we dare to tell people what the caloric content is that they're about to consume at point of purchase. I mean, how dare the public health community tell people exactly how many calories, how many salt, and other things are in their food. We're not the food police, but we are health educators. And doing point-of-purchase education is a wise move. I mean, how many people have, in their quest for health, run to the salad bar and put together a salad that has many, many more calories than the hamburger that I got. Okay? I mean, it's a challenge. And it's because you're not making informed decisions. You think you're making informed decisions. Once you decide to be healthy and to eat more healthy, and you want to make an informed decision, you would like people to know that they're giving them the evidence. I don't think that's being the food police. I think that's being a good health educator. I think that's being a good parent when you're dealing with your kids, or going a good husband or wife when you're trying to educate your spouse. And we should not back down from this. You know, we have people that push back against us on this, but this is what we do. You know, I mean, this is when you create doctors and nurses and pharmacists and health educators and nutritionists, this is what you get. Okay? And if you want to do that, fine, but you also get good health, because that's what we're doing. That's what you're asking us to do. And so I think we shouldn't shrink from this role and this role of trying to improve healthy communities by informing people what goes into their mouths and giving them some concept. You know, when you go to Europe, the plates are much smaller. The food portions are much smaller. But here in the United States, it's exciting to get not just the hamburger or the double hamburger, but the mega hamburger, right? You know, not just a quarter pound of beef, but a pound of beef. And now I think there's a 2-pounder, you know? Well, you know, I think, all right, if that's what you want to eat, but you ought to be thinking about the ramifications of that 2-pounder. And we're not doing enough of that, and I think we need to do more. Food labeling, is a big issue. You know, the FDA began doing food labeling again to tell people what's in the food and to begin regulating things like trans fats. And we're beginning to see the evidence from studies like our NHANES study, which looks at the chemicals and nutrients that we have in our bodies and correlating that with regulatory activity. We're beginning to see that we can actually, through good education of the public, strong regulatory action, impact those things that should or shouldn't be in our bodies. And so this is important, and this is something I think that public health needs to do more of. Health is about access to affordable and healthy foods. So we know that we have these things called food deserts, places where people don't have access to foods. I remember eagerly writing prescriptions for patients to go to the nutritionist and to encourage my patients to go to get healthy foods. And I remember having, on several occasions, the patients look at me and say, where? Where? Ward 8 in Washington, D.C. was one of the communities that was very underserved in terms of grocery stores. In the past, it's been a relatively low-income community. Until fairly recently, a couple years ago, there was no grocery store easily accessible in Ward 8 in Washington, D.C. I just spent 6 months last year in New York City on sabbatical. And I lived in a very nice part of town. I was actually at Roosevelt House on East 65th Street between Park and Madison Avenue. And I don't know how the 1% let me in their neighborhood, but they did. So it's a fairly ritzy neighborhood. I can't afford to actually go in the stores. I was a little uncomfortable even looking in the windows at the prices in that neighborhood. But like most New York communities, it's walkable, it's bikeable, it's green, it's a wonderful, wonderful neighborhood. And I, coming from the Washington metropolitan area, began to go through McDonald's and Burger King and other fast food withdrawal because they had these very nice delis and other healthy stores where I could buy safe, affordable, healthy foods. And I taught up at the School of Public Health up on 119th and 3rd Avenue. And it was always interesting. You could find a grocery store every few blocks on the way to school until you got to about 100th. And then after that, you saw, much to my satisfaction, the McDonald's and Burger Kings and the Kentuckys and all the fast foods. Of course, that was the East Harlem and the income level that that community was very different from the income level in which I was actually living at the time. And it was just amazing. All of a sudden, the grocery stores went away, you know? And we see it all throughout America. Where are the fast food stores concentrated? And where are the grocery stores concentrated? And, you know, this is a challenge. And in some communities, there aren't even the fast food places. They're just, there are lots of liquor stores, and there are lots of places where people can buy high caloric, high fat, usually overpriced stuff. You know, the cheapest thing as soon as you walk in the door, due to product placement, we all know that from the tobacco wars, the product placement, the chips and soda are right there in the front as they come in. Wouldn't it be neat if we could convert those stores so that they have a chiller for affordable fresh fruits and vegetables in those communities? Wouldn't it be nice if we could encourage the grocery stores to go into those communities to offer people fresh fruits and vegetables? And it's going to be important that we continue to encourage people to do this. One such initiative is the First Lady's Let's Move initiative and her Healthy Foods initiative, where she pulled together with another nonprofit several of the nation's leading grocery stores to try to look at ways in which they can begin to put affordable foods in communities. And hopefully I know this project is going on. I applaud the First Lady and the administration and these stores for doing this. I mean, these are the Walmarts of the world. These are the major food chains. You know, we may have other issues that we have to debate with those companies, but this is a good thing. Again, at the end of the day, they need to be fresh and affordable and in the community so that people can get to them. You know, health is about where we dump our trash. So I'm the health officer in Washington, D.C., and the 14th Street Bridge, the major bridge that comes in from Virginia into the District of Columbia, it was amazing. We used to have these, at the middle of the night, these haulers, which would be doing illegal dumping, come across the bridge, make the right turn, go into low-income community in Washington, D.C., and dump their trash in the middle of the night. Great public health intervention was working with the police department to catch those folks on the bridge and either turn them around or fine them and prevent them from dumping in the community. It's much cheaper to prevent them from dumping this stuff in the community than having to clean it up later. And also where we build these communities. We often tend to build these communities in places where the land is relatively cheap. And that's a problem because often that's where things have been dumped. And then you've got to clean up the ground. Or they then theoretically clean up the area to then build homes, but they really don't do the cleanup well enough. These things affect our health dramatically. And again, the idea of getting more people outside the health sphere involved in thinking about their role in public health so that public health and population health becomes a secondary occupation and responsibility for every job or discipline is not a crazy idea because they all play a role in doing this. You know, when the trash folks go on strike, it becomes a public health crisis really, really quickly. And their public health role becomes apparent to everybody when you get a rat infestation or when you get a child who's been pricked by a needle that should have been properly disposed of, but certainly wasn't removed. Those are big issues that need to be addressed. And obviously health is about the air we breathe, the water we drink, and the safety of the food that we eat. And we need to continue to recognize that's an important issue. Now, we're having a national debate about the role of government. I still believe that government's important. It does what we cannot do individually and what we must do collectively, and that there's regulations involved in that process. And I would argue that those that think that regulations cost things, of course, everything costs something. But again, if you're sick or you're dead, regulations aren't going to do much for you. And so I think the public health has a role to vigorously enforce the regulations that we have, and to do so in a fair and effective manner, just like everyone else who has a regulatory responsibility as a way of trying to build healthy communities. Health being about places to play. Now, we have some that argue that we shouldn't spend public money and we shouldn't spend public health money on places for kids to play. But I would argue that the evidence is real clear that children who are in constructive play do better in school, have less mental health problems, and are much more successful than kids who are not in constructive play. They're fitter. They learn to play well with others, a skill that certainly would pass them and do well by them as they become, elected officials and leaders of their community and business players. I think we probably ought to do a study looking at places to play and for some of our colleagues in leadership positions and see whether or not they were devoid of opportunities to play when they were children, and that's why they do what they do. But that's another thing. Health is about quality education. This is a very famous slide, and again, for those who can't see it, it basically shows a strong correlation between the mother's education and infant mortality. And this has been shown throughout the world in every culture. This is not a cultural thing, okay? Mother's education, those mothers that are well educated, their children do better. They have a lower infant mortality. Now, whether or not that's a surrogate for other issues in the society, socioeconomic status as a key example, it's not real clear. We don't know all the reasons for this, but it correlates, and this correlate as well, shows very well, regardless of the nation. So education is important. I argue sometimes maybe we ought to stop spending so many dollars on health and putting some more of those dollars in education. We might do better as a society in terms of the overall health and well-being of our nation. Health is about a range of internal and external stressors. Those are big issues. There are mental health issues involved, but it's important that we recognize that equity, racism, discrimination all play a role in how people react to their environment and how the environment reacts to them. Their perspective on themselves, people's understanding of how they deal with stress and things like that are very important. But these are other ways that are important to a healthy community. Health is about quality housing. I would argue very strongly that most of us would be eager to live in the nice house there with the great lawn and would not be so excited in living in a house that's torn down and has lots of places where you can injure yourself and has got rats and mice and roaches, and it's just not a very pleasant environment. And that's a challenge because we have a problem with, continued problem with homelessness in this country. So not only do we have people that have to make a choice between really great housing and poor housing, but we still have a problem with people that have a choice between poor housing and no housing, which we have to address as a nation. And that's increasingly a problem for our veterans that we need to address. And the recession did not do anybody a favor around housing. And as we rebuild housing, I saw that housing is beginning to pick up again. We need to start getting the homeless into these tracts so they can get the benefit of some of this housing as the housing market begins to recover. There's a lot of broad community things that are important. Let me just point out one of them that's obviously been in the news lately, and that's the issue of safe communities and the violence communities and the issues around guns. This is a nation that values ownership of firearms. That's probably true. But having a gun, responsibly using a gun, and knowing when not to have a firearm around you are important life lessons. And the problem is that for far too long, we have not asked the evidence-based questions that we need to ask around firearms. And so I know that at APHA, we are strongly in support of doing the research to ask the right questions. When are firearms protective? When are they not? Who should have them and who shouldn't have them? What is the best way of making sure that the right people have them and not the wrong people have them, okay? You know, for many, many years, the British police didn't carry firearms. There are nations that have guns in every home, and yet they have a low violence rate. What's the role of our culture? What's the role of the media? We have not, you know, we're not asking those questions aggressively enough or often enough to solve these problems. I grew up in Chicago, and as you know, right now Chicago is having a terrible, terrible epidemic of firearm-related violence. I was in Washington, D.C. when we were having drive-by shootings as the health official and then as the EMS director. And you know, these are serious problems, and we need serious people, as they say, to solve them. And now's not the time to shrink from this. And obviously the recent shooting that we had, I think, was finally the last straw. And I hope that our nation will recognize that this is an essential component for us to be able to get up every morning and have the comfort that we can walk out of our homes and feel relatively safe as we go forward. So the Affordable Care Act does have some population health measures in it that I just want to point out. And there's a range of things that are in there to try to help promote health and well-being. In interest of time, I won't go through all of them, but I just want to point out one, which I think is this Prevention Council, which is chaired by the Surgeon General. The Surgeon General is leading basically a health and all policies concept where they're pulling together several federal agencies to think about health and well-being. They've put out a plan. That plan is an important plan to try to begin to drive us to think more about wellness and health. I think it's an important effort. I applaud the Surgeon General for their efforts. They put out 2 reports. They'll have another report to come out this year. But the idea of this council is for us to begin thinking about how do we make sure that people are well and healthy versus how do we make sure that we fix people. There are other people that do that. So this report is going to help us begin to think about ways in which we can build our communities differently to improve our health. We also have the Prevention Fund, which many of you know has been under political attack. And by the way, I want to thank the Maine Public Health Association for your strong advocacy on a part of supporting the Prevention Fund. You'll have people that will tell you that the fund is a slush fund. Well, no more than the slush funds that we have at the CIA or the slush funds that we have in defense. It's an essential fund designed to protect and improve the health of the American people. And we need to remember that. For the first time, when we looked at health expenditures, for the first time, governmental public health expenditures dropped compared to every other expenditure in health, which grew, which demonstrates what we've been saying, that we've been cutting back on public health, which is underfunded to begin with. There's no way in the world that you can get a healthy community if we continue to underinvest in the population health and community health. We're just spinning our wheels if we continue to underinvest in those areas. And I know money is tight, but sometimes there are times in which you just have to splurge a little bit in order to build something that will give you a long-term investment. And population health and community health is one of those activities. Right now, it's doing it through a process called community transformation grants. We're designed to engage communities. These community transformation grants are important grants that go into community. They're a way for us to build healthy communities. It's a way to get communities talking about tobacco and wellness and fitness and building places for people to walk and exercise. And those are important things for us to do. It's important that we measure what we do. This is a neat chart. So this is a map of the United States showing the differences in mortality in various parts of the country. And as you can see, in some parts of the country, there's a huge difference, so that where you live makes a big difference on how soon you die. Now, that may or may not get your attention because it's between states, and sometimes people don't, recognize that that's important. So I point this one out. This is a chart. Those of you who've been in the Washington, D.C. metropolitan area, this is the train lines in Washington, D.C. And you note there's almost a 10-year difference than if you live in Washington, D.C., than if you live in some of the outlying suburbs. I'm pleased to say I live up there in the 81% area, so I'm assuming that's how long I've got. But it's amazing, you know, and I would argue, where's the outrage? You've got a 10-year difference. This is not a secret to anybody. When people die 10 years sooner, that's, and people in the same community, you know, the people that live out in these outlying areas work in the area where people are dying prematurely. And so I argue, what's the outrage here? So we need to be accountable. There needs to be some public accountability for this. We need to engage a whole range of people as part of that accountability. One of the things I've learned about engaging the public and trying to get the public involved is from my friends who have tried to close firehouses or schools. You ever tried to close a firehouse or a school? Can't do it. Because the public rears up. Even if you don't need the school or firehouse, the public is there to demand an explanation. And you got to do a lot of explaining when you want to do that. And when I was a health official, I don't know how it was for you, but when I was a health official, there were very few people at my public health hearings. There were lots of people at my Medicaid hearings. But when I wanted to do something in public health, very few people showed up, unless we wanted to euthanize a ferret. Then the room was full of kids with ferrets. But other than that, and one other time when the annual effort to repeal the motorcycle helmet law, where the room was filled of big people with leather jackets, and I would always have to very carefully say, excuse me, to get to the desk so I could get my testimony. But with those two exceptions, the room was never packed full of people concerned about public health, including the folks that are now arguing we need to have more mental health treatment, et cetera. Never saw them at a public health hearing talking about mental health and treatment, et cetera. And this is important. And so I think public health leaders learn from that message. We need to build the capacity and interest of people to come in and fight for public health. We know very clearly that public health does its best work when nothing happens, and when nothing happens, you're invisible. And we need to find ways to make it visible. So, we're talking about violence. A great story, unfortunately, is the number of kids who died from child abuse. But a better story is the number of kids who didn't get abused because of prevention efforts. But it's hard to tell that story. It's many, many more children were protected. It's a much better outcome than the death story, but the death story is more sensational. And we've got to figure out how to make the prevention story sexy to the people that listen in the media and the people that tell stories. Everyone has a role in producing these healthy outcomes, from business, from politicians, from you and me. I would argue that elected leaders have a special responsibility because of their requirement of the law and their purse strings. But we all have a responsibility here in terms of that. In the end, this is the quote from Martin Luther King about the love community. But in the end, this is what we're really trying to accomplish. You heard the very detailed discussion around beloved community by Donna earlier. We only get there if we think of this thing in a holistic manner. We need to make sure everybody has access to health. One way to do that is, major way, is through health insurance. But we also need to recognize the fact that there's a range of other things that we do every day that we don't think of that have dramatic impacts on our health, whether it's transportation or housing, whether it's the environment. These are all things that you do either in your clinical practice, as you go out and you finish school and you go out and you do the work that you do. You're impacted this from every day, from the moment you wake up in the morning to when you go to bed at night. There's a public health intervention surrounding you and making you safe. We've not been very good at telling that story about that public health intervention, but it's there every day. It's in the chemical retardant, the flame retardant clothing that your children wear at night when they go to sleep. So if for some reason there was a fire, their clothing wouldn't quickly catch on fire. It's the water that you drink, whether it's bottled water, so we're trying to get away from bottles, or it's water from the faucet. And you know, still too many people think they've never been impacted by a public health service, and yet every time they turn on that faucet, they're benefiting from public health. Every time they go outside and they don't choke because of the quality of the air, they're benefiting from public health. And all of those things together collectively create the beloved community that we want. With that, I thank you, and I was honored to be with you today. Thank you. And I certainly have time for a few questions. And I know some of you had to leave at 1.
So when you ask a question, make sure to locate someone with a microphone so that everyone can hear you, and raise your hand.
Does anyone have a question? You mentioned a lot of different types of public health, but actually at your last statement, you mentioned people with flame retardants aren't able to, they can die if they get in fire and such like that. But you didn't mention the environmental impacts and the health impacts of flame retardants that are really toxic, and then going into that disparity that we're having to deal with, and there's so much unknown.
You know, we live in this amazing planet which has trade-offs. And every day we make trade-offs. Bottled water is convenient, and we want people to drink more water. And yet we're trying to reduce the amount of trash that we put in the environment, and even the process of creating bottles. The fact that, some of the chemicals that we put in materials aren't as safe as we would like. No question about that. And they're trade-offs. And everything has this point in time. I remind people that while we believe vaccines are safe and effective, the pushback we've gotten against vaccines, when even though we know there's no autism link, but the pushback that we're getting is because in many cases people don't remember these childhood diseases. I mean, parents used to fear if their kid got a sore throat, that it would be strep throat. Strep throat was a dreaded word. Mothers would rush their kids to the doctor's office to get them treated for strep throat. We had a new antibiotic called penicillin that easily killed strep throat, and strep throat resulted in a range of death, airway obstruction, chronic renal disease, and a whole range of bad things that happen because of strep throat. Today, we love antibiotics, but we're very much concerned about antibiotic overuse. And so in a time when parents are no longer rushing their kids to the doctor to get their antibiotic for strep throat, but they are rushing themselves and their families to the doctors for other antibiotics, for even a sore throat. And of course, antibiotic overuse has resulted in many antibiotic-resistant organisms. So I think the solution to your question is that we need to continue to do more research. We need to continue to find out safer and more effective chemicals and things that we can use that have less side effects, less complications, less trade-offs. When we do discover something's bad, then we pull it out of the environment, like we've done with asbestos and like we've done with trans fats. That's the only way we're going to make progress. But there was a time when people were very much worried about your clothes catching on fire and burning. And we're not seeing that today because of the retardants in our clothes.
You talked a lot about physical health and gun control and those sorts of things. I just wanted to know your take on the role of mental health and the things you discussed today.
Yeah. So let's first continue to argue that we're pleased that we have parity for mental health. It took us many years to get there. But now that we have it on the books, we need to behave that way. We still have far too many people with mental illness who don't get diagnosed because of people's concerns about someone will find out about it, the way that they get treated in the workplace, the way they get treated in their families. We still keep Uncle Luigi with his schizophrenia in the closet, and that's a problem. And we need to deal with that. We need to start making sure that we have pay parity as well, so that people will have access to those services. Now, we're about to have a major debate about the role of mental health and firearms. We need to make sure that debate is the right debate, so that we both protect ourselves from injury from firearms, at the same token that we don't blame the mentally ill for that problem, because we know that people who have mental illness are not necessarily more violent than the rest of us, and then we need to make sure that we, again, another one of those trade-off questions, that we get the right trade-offs here.
So we know a lot about the changes that need to be made to make the population healthier, and we know these health discrepancies that are creating these health inequalities, but it seems like the changes that really need to be made are sort of out of my hands as a future clinician and really in the hands of policymakers, and I can't help but feel a little bit helpless because patient education really can only go so far when you're working in an underserved community with very limited resources. So what advice do you have for a future clinician as to what difference I can make and how to fight that feeling of helplessness when working?
Expand your definition of who your patients are to include your policymakers.
Yeah, I guess I'm talking in a primary care setting, when you're telling your patients to eat healthier and to exercise more, and they just can't do that, and what really needs to be done is more grocery stores and access to healthier choices.
Write your policymaker and say, I saw 10 patients today, they didn't have access to a grocery store. Work with your local health department and your state health department to support them as well. Show up at the hearing and tell your clinical story about your 10 patients that didn't have access to that. Obviously, I'm going to say join the local public health affiliate, your local organization. Participate on the national level. I think it's very important that clinicians have got to think much more broadly about their role in providing health services. We cannot treat our way out of this crisis. We have got to use evidence-based policy and reasonable policies that we think work, and then we test them to make sure they work, to try to move things forward. And be part of the solution. And to the extent that we say there's only so much I can control, well, of course, there's only so much you can control every day. That's true. But you have enormous influence. Let me tell you, when you write a letter to your member of Congress, either or your local elected official, or even the state or local health department, that letter has much more power than me banging on their door and talking to them, because you're a constituent and they care what you think. And if you don't tell them what you think, then what they do, of course they use their own judgment or their own ideology and views, but what more importantly they will do is say, I haven't heard anybody say anything about that. And you take away that argument if you write them and call them. That help?
Okay, I just have a question. When we were going over junk food and taxing junk food as a way to maybe increase the health in people, what does that money that's taxed towards go to? Does it go towards accessibility towards more grocery stores, or where would the funding for that go?
So the funding for the quote-unquote sin taxes or food taxes, et cetera, they go wherever you can politically make them go. The challenge we have for public health is that they often go to the general fund and they don't go to a dedicated fund, because legislators like them to go to the general fund, so then they can reappropriate them wherever they choose to, appropriately so in some ways, later on. So I think that you have to make a very strong argument that taxes raised to improve health ought to go to improve health. Now that's what's happened with the tobacco restitution funds that we had and the tobacco settlement funds in many states. But there were some states where they actually went to aid the tobacco industry. I mean the tobacco industry, yeah, and that was a shame when that happened. but you've got to continue to make a powerful argument. The other thing you've got to do is show the return on investment. So if you invest in public health here, then we will gain here. And in fact, this year's National Public Health Week, the theme is return on investment. And so we're looking for public health folks to show what the return on investment is if we invest in a variety of things in public health. And so I hope that you and your colleagues here will engage. It's the first full week in April. We'll engage in National Public Health Week and show the community, the public, elected officials, yourselves, what that return on investment is for public health.
Other questions?
I have a question about computerization in the health and medical fields, and how to sort of frame that both in the context of cost. How do we justify putting money into computerizing health records, or even at the state or federal level, but also the issues of privacy around that?
Well, okay. So obviously privacy is an important issue. Let's start with that because we're all very concerned about privacy. And I would argue that it's an important issue. And right now, the financial community has figured out how to keep your records relatively private. The IRS can certainly keep your tax records private. We found that out during this election. We're concerned about privacy, and I think it's important, no question about that. However, a lot of what we're talking about isn't about your records. I have gotten all day today reminders about where I was supposed to be, both for the breakfast we had this morning, for the dinner we had last night, and for coming to this meeting. I can assure you that I will get no such reminders from any of my clinical appointments. I do get it from my dentist. And when I had a cat, I got it from the vet. That's not a privacy issue, okay? Unless you don't want someone to know you're going to the doctor at all. I think that you will see a lot of studies that say, well, the fact that we're using more, we've made the process of clinical care more efficient because we've automated it, is actually driving up costs because that part's become more efficient. Well, they're not measuring right. Those studies cannot be right because they're not measuring all the costs. The cost of me not having to go to a doctor's office because the appointment was changed, the ability for the doctor to do what a restaurant does and give me send me a note and let me know they're running 15 minutes late. I can go do something for 15 minutes before I have to walk in their office, so I don't have to sit in their office all day long. The fact that if I fall out right now, hopefully it won't happen, you'll have the clinicians will have no access to any of my medical records. They're starting from scratch. African-American guy, 60 years old, overweight. They don't even know I'm a non-smoker. They don't have any of that information. And having that automated saves a lot of time and money and effort. One story. So I'm at Walter Reed. I'm the ER director at the time when we automated the laboratory. And what happens is there's a little gremlin that runs through the hospital at night and pulls things off the charts. Very efficient person. I don't know who it is, but they're very good at what they do. And they always do it for the people that got to go to the operating room at a certain time first. And so what happens is that everyone panics because the lab results aren't on the chart. And what do? They don't go try to find the lab results. They order another CBC or a set of electrolytes, and they just redo the test. What we discovered when we put in lab kiosks and everything went in the computer, we killed a few more trees, but we had a dramatic reduction in overutilization of the lab. Because what then would happen was they'd come down to one of these kiosks and pull up the lab result and stick it right there on the chart. There was enormous savings in doing that, both in time, effort, and money for repeat tests. And I think studies that are done right, that look at the full cost savings across the health system, will begin to see that. The number of times that tests get repeated when a person is hospitalized at one hospital, discharged, and ends up at another hospital, and all those tests get redone because they don't know. They got to do them right away. They get done in the first 24 hours. When if their record was parked somewhere and everybody could get to them, they would see it. The number of times nursing homes send someone to the hospital because they don't have the information. The lab test was done yesterday, but they don't know the urinalysis was negative, and therefore the person has a fever and could not have a urinary tract infection. And that may or may not stop them from going to the ER, but I can tell you as an ER doctor, the number of times I saw patients in the ER after an exhaustive workup, we finally get the records, which are usually this thick, and you finally find the one page that you wish you had that information before. You then send them back to the nursing home. You've now paid an ER cost to come to the ER, you have an ambulance cost to come to the ER, an ambulance cost to come back to the ER, and then of course all the work up at the hospital. Much cheaper to have a system in place. And by the way, the real evidence is that every other industry that's automated, their prices are crashing to the floor. You know, grocery stores are now automating, as you know, the checkout line. They're not doing it because it's costing them money. They're doing it because it's much more efficient. Now, we might argue that people are losing their jobs. That's another debate. But every other industry is showing reductions in costs. The health industrial complex continues to find the most interesting ways to escalate costs. And my argument is that needs to stop. And IT solutions are one way for us to do that.
So thank you for your service and leadership, because you've been in this role for a long time. And I'm wondering if you're asking yourself, what are you still passionate about, and what is it you hope you still will accomplish in this role?
Universal health care for everybody, and I see the I see the Affordable Care Act as a venue to get there. I think that I love to see science and evidence become more ubiquitously used, and I'm not going to say that everything that we in the science side of the house is always correct, but we try very hard to be right, and I think we ought to have vigorous debates with all sides around issues. I'd like to see us take a serious look at climate change. I'd like us, obviously, to look at firearm-related violence. I'd like us to look at violence, to which firearms is a component. I would like for us to build a sustainable public health system. If I accomplish just those things, then I can go to Disneyland feeling quite comfortable. There's somebody right behind you.
Well, since we're convened around Dr. King today, I thought it'd be fair to ask you whether you see any role and see any leading examples, perhaps, for the faith community, churches, synagogues, mosques, Native American, in other words, various parts of the faith community in population health, both health promotion and disease prevention in a really constructive way, or not?
Yeah, there's no question that the faith community can be a major mover and shaker in all these areas. I mean, their core views around the appropriateness of taking care of one another is central to what we do, and we don't engage them nearly often enough as part of our coalition. You know, having, you know, excuse me. I know there was a time when we finally convinced a lot of the pastoral community and faith community in Washington, D.C. To pick up HIV and AIDS as a as an issue. Now, for many reasons, they had to get through their concerns and their views around the gay issue, around the gay community. But we were very successful in getting them engaged in Washington, D.C. when I was a health officer, to recognize that, that's a different discussion that they ought to have, that they needed to address the HIV/AIDS issue. We were able to convince them to engage us in the issue around infant mortality as another issue, and we were able to engage them very effectively, again, around early initiation of sex, which they would support in the church, but to get them to talk about that openly versus the small counseling sessions that they would use with troubled teens, and recognize that they had troubled adults with troubled parents in the audience, who had problems that they needed to address, and that they could do that from the pulpit. So we were very much able to convince them to do that and to build ministries around it. And so you can do that. They have to be well informed, well educated, and you got to show them how they can do this for the long haul, so it's not a quick issue for them, so that these diseases don't go away. And try to get them committed. And they can do high blood pressure and diabetes and all kinds of other things at the same time. So building that partnership is very, very important. I know that you're doing that now with the grant that you got on immigrants, and trying to build at least partnerships across a variety of groups. I understand the faith community is involved with that as well. So that again, hippie, yay for you for doing that. It's very important. I'm glad you're doing it.
Any other questions? Okay, so Dr. Benjamin, on behalf of UNE, thank you so much for coming again. He will be around afterwards.